They have a order, the Winnebago County Community Women. Okay, Wednesday, January 7th, 2:05 p.m.
Present.
Dr. Copeland. Dr. Chardini.
Here.
Dr. Doris. Here. Dick Cooner. Tim Abrams. Jeff Nielsen.
Here.
Dr. Kenny. Mohammed Yunus.
Yeah.
We have public comment today, and actually we have quite a few public comments. So I just kind of want to go over the basic understanding, at least from the board's perspective, on how public comment was done before us. Everyone that's speaking will identify themselves for the record. And each comment is limited to 3 minutes. And members of the public may be asked to avoid repeating comments that have already been made, although they may be given the opportunity to indicate they agree or disagree with the earlier speaker. So I am going to start it off today with Angie Walker, giving the first public comment.
Thank you for having us here with you today. I am here because we have come into a critical moment. As actions being taken by the federal level threaten to disrupt and potentially withdraw funding that our community relies on to serve people experiencing homelessness. Today, we are here to make the Winnebago County Mental Health Board aware of our local homeless coalition and a serious situation that is affecting our providers and potentially our entire community. Our homeless program in Rockford has made great strides over the last 10 years, receiving accolades from both state and federal partners. Rockford is one of only 3 communities in the country to reach functional zero for 2 populations, veterans and chronically homeless. And currently, we are about to receive confirmation on a 3rd population, which is youth. The City of Rockford Health and Human Services Department serves as the lead entity for the Northern Illinois Homeless Coalition. The City of Rockford is the collaborative applicant for the HUD Continuum of Care funds coming into our community. Right now, that is about $2.9 million, and approximately $2 million of those funds do stay right here in Rockford. HUD funds pay for 7 separate grant programs, all permanent housing programs. In order to be eligible for these programs, individuals or families must be literally homeless, which means they're either in shelters or places not meant for human habitation, and they must have a diagnosed disability. We are currently assisting with rental payments for 194 households and 334 individuals total. HUD and the current federal administration is attempting to change all programming, revert our programs to policies from approximately 15 years ago, and it threatens our current initiatives and the success, thereby making the people that we are currently serving homeless again. If these changes move forward, they will directly harm the most vulnerable members of our community. And I realize I didn't say my name or where I'm from when I started. So I'm Angie Walker. I am the homeless program manager for the City of Rockford Community Action Agency. Thank you.
Todd Kisner.
Good afternoon. My name is Todd Kistner, and I am the chair of the Northern Illinois Homeless Coalition. And I'm here to advise you of what HUD has planned in their FY25 grant application. HUD is endangering every homeless program funded through the Continuum of Care in our county. HUD is proposing in this FY 2025 grant application to implement a 30% cap on permanent housing for all COCs. Currently, 89% of our roughly 2.9 million goes to permanent housing. With this new cap, that knocks our funding down to $833,000 With currently our largest permanent housing program is 1,079,000, which is already over that limit. Currently, we have 136 permanent housing units funded through the COC. With this change, we will be down to only 40. In the past, 90% of our COC funding has been guaranteed to be funded for the next cycle. And the remaining 10% has been on a competitive basis. And based upon the score given to the COC, we may be funded that 10% or we may not. Under the new proposed FY 2025 application, HUD is allowing only 30% of our funding to be guaranteed. We then drop the 70% into that competitive bucket, which then could potentially, we could lose all of that money depending on our score and what HUD determines. Also, as Angie alluded, HUD is recommending to change from permanent housing projects into transitional housing programs or street outreach programs. For this new transitional program, HUD is going to require that the tenants in those houses require 40 hours of case management with the sponsoring agency, which will be taxing for those agencies. If you think 40 hours a week, that's pretty much a full-time job for one tenant and or one staff member to ensure that they're engaging with those folks. Talking about disabilities, HUD has now defined in this application that a disability is only physical and or developmental. They're leaving out mental illness and totally excluding substance use disorder. And finally, HUD is looking at things detrimental to our fight against homelessness, such as camping bans in communities, homeless providers in helping law enforcement criminalize homelessness, and other harm reduction opportunities as positive things, points to earn on your application, and penalizing communities that do not do these things. Thank you.
Mayor McNamara.
My name's Tom McNamara. I first want to just say sincerely thank you to all of the board members who serve and take your time to serve our community in such an important capacity. I'm here along with others to really bring light to the issues that our community very likely will be facing. To put it as simply as I can, we are very likely going to lose millions of dollars. And what that'll mean is almost immediately, there's a high likelihood that hundreds of our residents, our friends, our neighbors, our colleagues will be homeless. And I don't want you to think that this is just going to impact HUD or the Health and Human Services Division of the City of Rockford. I really believe that this will have far-reaching impacts and really impact the entire city of Rockford. If HUD's proposed changes take effect, the entire safety net can disappear. And many of the currently housed individuals we serve will be at immediate risk of losing their homes, while the people who are unhoused now will have a far more difficult time in finding housing that is stable for them and safe for them. With these things being stripped away, the mental health progress that we have as a community and our individuals have helped create and get to this level will collapse. This is not just a homeless issue, as I've stated, this is a community-wide crisis. It's an immediate threat, and it's intense stress on our emergency services, our hospitals, our libraries, our public organizations, all of which are already overburdened and underfunded. We cannot afford to make our partnerships less effective, especially with the great work that you all have done to help make so many partnerships more effective. To protect our community's public health and safety, we must maintain the funding structures that allow us to keep people off the streets and keep them in stable environments that we know is best for them. I'm going to just go a little bit off script since I have 55 seconds and I'm a Maximer. I'm not going to give up my time and say that we're not here to ask you for money today. We're here to simply make you aware of what I think is going to be a dramatic change for our community and have devastating life impacting effects on so many of our citizens, the most vulnerable, those that you are funding so many phenomenal organizations to do great work. It's going to directly impact them. It's going to directly impact those residents that they are serving. It's going to directly impact those staffs at those organizations that are already overburdened and can't get all the work done that they need to get done. There's going to be so much more to do. And if we don't, with the federal government, in my words, not staff's words, I believe failing us, we as a community are going to have to step up, and we are going to have to dig deeper into all of our existing partnerships and funding streams to make this work for our most vulnerable residents. Thank you.
Good afternoon. My name is Melissa Crowell. I'm the director of the Mental Health, Housing, and Homeless Programs at Rosecrans. As Angie stated earlier, Rosecrans has a partnership with the city of Rockford, and we run a HUD housing program called Shelter Plus Care. This has been in existence since the 90s, and we specifically serve individuals that have serious mental illness and were literally homeless prior to being housed. While there's been increasing suggestion that our programs don't work, that's what's kind of being put out there by the federal government. We know that they do. We know this from our data, and we know this from the lived experiences of people we serve. Our program works because it combines permanent housing, integrated mental health services, and long-term supportive relationships with other community partners. To illustrate this impact, I just want to share one example. Becky came to Shelter Plus Care while experiencing literal homelessness, and she had significant mental health challenges, substance use, and domestic violence issues. She was accepted into the program and remained housed for 4 years, during which time she received mental health and supportive services through her caseworker. During that time, Becky returned to school, earned her degree. She eventually graduated from our program. Since then, she's gotten married, purchased her own home, regained custody of her grandchildren, whom she's now raising, and she even worked in our Shelter Plus Care program through Rosecrans. Today, she works for the city of Rockford as a housing advocate, providing the same supportive services that once helped her rebuild her life. She's here with us today. She's allowing us to share her story. Her story is not an exception. It's a clear example of what is possible when people are provided with stable housing, appropriate supports, and the time needed to heal and grow. These programs change lives, strengthen families, and improve our entire community. Thank you.
Shannon Kopp.
Hello, my name is Shannon Kopp. I'm with the Rockford Fire Department. So currently, this grant process is on hold due to several large challenges throughout the nation regarding the legality of this grant. While the application is officially due on January 24th, we are not actually allowed to work on it. We are hoping that through congressional actions, we'll be allowed to get our fiscal year 2025 funding as promised in fiscal year 2024, giving us at least some time to plan and reorganize our programs in a manner that will allow us to be funded. We anticipate that this will be updated tomorrow on January 8th. We're hoping to hear some news then. Again, we appreciate you taking the time to listen to us today, and this is a very dire situation that our homeless providers and our homeless population is going through right now. These proposed changes would change the entire landscape of our homeless services. We know that housing is a priority and a need of our mental health board, and we felt is necessary for you to be aware of what's happening. Making the changes that HUD has proposed will make people homeless. The people losing their housing will likely be ineligible for our transitional housing programs, and even if they could get a place, it will be temporary. Many of the people in our program are very ill, and they would not be successful without the wraparound services that we currently provide. Our permanent housing programs currently serve those with the most serious mental illnesses, disabled family with children, homeless youth, and who are often very times dealt with serious trauma. All of these people would be falling through the cracks if it wasn't for the wraparound services, and we want to keep that from happening again. We are working together with all of the partners to come up with a plan on how we're going to handle this potential loss. Any input or assistance that we can get from the Mental Health Board would be greatly appreciated. And I want to thank each and every one of you for your time and attention.
Monthly activity report, is there highlights for November and December?
Yes, I will highlight that we are this week finishing our local data collection around the strategic plan 3.0. And we had, happy to say we got 235 public responses on the public survey we had. Our goal was to get over 200, so we exceeded that goal, and we had more than 300 different perspectives represented in terms of frontline staff of agencies, administrators of agencies, those with lived experience, family members of somebody that has a mental health or substance use disorder, and then general community members. We also had more than 50 environmental scans for direct service providers, which goes through all the components of the community support system. And something new that we implemented this year to get local perspective and context on the CCBHC hub and spoke model were the key informant interviews. And we've now, by the end of this week, we'll have conducted all 18 of those key informant interviews. And then we'll start our data analysis and synthesis. And next month, we'll be bringing forward to the board an empowerment evaluation that we did last round, which will get more into mission, vision, and values. And then we'll start curating and presenting some of the data to you over the months of March, April, and May to start developing and finalizing strategies and goals for the next strategic plan.
Thank you very much. Moving into our action items, we only have one today, and that is I need a motion to approve the November meeting minutes. Okay, Jeff, second. I can't, the glare did second. Okay, you got that. Any discussion, corrections, additions? Hearing none, all those in favor, please say aye. Opposed, same sign. Thank you. Moving into our discussion items, we're going to have an update of our fiscal year 2025 budget. Jason is going to go through that with us.
So we've closed out the fiscal year 25 budget now, which ended in October. And then we were able to finalize submissions through December. So that closes out also the program year 4 grants, core program grants, and a number of accelerator awards. Good news is that it was the highest year of spending on program grants, exceeded last year's number, did not reach the goal that we had for the year. So spending was still a little under what was anticipated or budgeted, and revenue was a little higher than budgeted. So we essentially kind of broke even on the year, a little bit of revenue back into the reserve, but pretty even overall. On operational budget, everything that we had was under budget, aside from the legal costs that were mostly associated with one particular issue that the board's been made aware of. And on overall key performance indicators, total budget utilization for the year ended up at 66%. Our goal is to get that between 75 and 80% on an annual basis. Administrative costs were at 3.5% of the total budget. Goal is to have that between 3.5 and 4.5. So we're on the low end of that goal. Goal is to get the reserves to 12 months of total budget. Right now, it's still at 21. We did not make any progress on that particular metric this year. So may need to be more aggressive in future grant years with how much is allocated. And cost per grant administered or grant managed was actually at 14,000, which was under our goal of 15,000 on operational expenses per grant administered. And the revenue growth rate, again, just continues to boggle my mind and my conservative predictions. They would just always exceed our prediction. It was 8.7% on revenue growth. And based on the research we've done, we should be budgeting at 4%. If we look at final numbers for fiscal year 25 and what was budgeted for 26, we're at a 4.4% revenue growth on budget. So if we see consumer spending slow down at some point, then we might be right on budget for that at 4.4%. Any questions?
Yeah.
Dr.
Jason, could you go back over the, I'm thinking about money expended is still below what you targeted. What did you say, 60 or 65%?
The goal, again, this is just kind of benchmarking against similar type operations, other funding intermediaries or public grant administrators. The goal would be to get to 80% or between 75 and 85 with a little bit of variance of what we budget to actually be spent. And this year we came in at 67%, which was actually our highest year. But go ahead. Yeah.
Key reason for that, what? Is it still programmatic timing of expenses, or is there other, what is the real reason behind that, the key reason behind that?
The expenditure reimbursement grants, the board distributes funds based on actual expenditures and receipts of expenditures. And the expenditure at the program level has not been as high. It's still not achieving what we're benchmarking or hoping for to be at 80%. It's coming under that considerably at the program level.
I seem to remember in our early years, there were issues, particularly around hiring and staffing, that was causing a significant lag time in executing on funding the grant requests. Is that still an issue? Does that still remain?
It's not nearly as the same issue when we look at positions filled, I would say in aggregate or on average, but turnover, when there's staff turnover, that creates gaps and those gaps add up. But when we look at it over the course of an entire program year, it looks like majority of the positions are filled. But sometimes that turnover does create a gap in spending. Mental health field.
Simple. Yeah.
Yeah. I know. Thank you. Well, other counties we found are between 10 and 15% on average. I think 12% is the overall mean. So we're pretty low for a mental health board, that's for sure. Yeah. Thank you.
Any other questions? All right, moving on to another discussion item, the HIPAA compliant rideshare update.
Give me one second, Reagan. I'm going to get your slides up for you.
All right, so we have total rides broken down by month. Canceled rides are rides where there was either a no-show client or the program or operator canceled for whatever reason. We hypothesized the June totals are so low because the program was just starting at that point. And other than that, there hasn't been any really discernible patterns and changes of usage. The median cost per ride over each month also does not show any kind of discernible patterns. It's important to note that the outliers were removed from this data in order to get the most accurate measurement of central tendency. So this does not include the additional service charge that is also applied to every ride, and that total is usually about $6 per ride. My hypothesis is that the peak in November is due to a higher concentration of expensive rides such as MedRide, and thus the outliers did not remove as many upward bound rides, and so the median was driven up in November. Other possible reasons for an increase in the median cost would be just a greater proportion of expensive rides compared to the Uber Health rides, and then the rides going a greater amount of miles. We also created a map to show what zip codes were being served by the rideshare service. So within each zip code, you'll find the number of unique passengers residing in that area. 61103 and 61101 have the most unique users with about 13 unique users in each zip code. And then these 6 organizations have been active users of the rideshare program throughout the first 6 months. So Brightpoint, Lifescape, Marshmallows Hope, Rockford Barbell, Rockford Fire Department, and then Winnebago County Brick and JRIC. So some of our programs were able to provide us with some both positive feedback and areas for improvement to share with you today. So after aggregating and summarizing testimonials that were sent to us by our funded programs, clients and programs were satisfied by the service and grateful for its existence as they were able to attend appointments in mental health care that they might not have been able to get to otherwise. The removal of the barrier of transportation allows clients to focus on one less barrier as they move through their journey. In one client's case, the social connections they made in programming then turned into a consistent ride from their peers, and they no longer needed the assistance of the rideshare program. Minors and families experiencing the transportation barrier wishing to use the service have come across 2 challenges. The first being the vendor policy about unaccompanied minors and parent anxiety over their child traveling alone to appointments. Other clients have expressed some discomfort and reluctance using Uber Health, and it's important to note that other clients have stated that the drivers were nothing but kind, accommodating, and respectful during their rides. There has also been some confusion surrounding when to use the rideshare service. When we started the program, the instructions were to check friends and family for rides, public transportation, Medicaid ride funding, etc., before using the service. Some programs have struggled to define what really counts as that last resort ride and would like clarification in order to ensure all programs are using rideshare as intended. We intend to explore these concerns and any others that our programs bring up with focus groups that are going to be hosted within the next few months. And then finally, before I turn it over to Jason for the financials, I'm going to read a testimonial that was shared to us by our MAH program. During the pilot year of the HIPAA-compliant rideshare program, one patient's experience clearly demonstrated how reliable, supportive transportation can be truly life-changing. The patient is an adult woman living with depression, limited mobility, vision impairment, and significant social stressors. MIH engaged with her during a time of crisis and provided transportation to her initial walk-in mental health assessment. Due to her limited vision and recent discharge from rehabilitation, MIH assisted her with safe ambulation to and from the appointment and with completing required intake paperwork. She arrived physically fatigued and emotionally drained. However, with this support in place, she was able to complete the assessment and become established in outpatient mental health care. As a result, she was successfully connected to ongoing counseling and psychiatric services, appointments she otherwise would not have been able to attend without the support of the MIH program in collaboration with Kaizen Health as a transportation partner. Following the initial assessment, the patient disclosed that she had experienced financial exploitation by a family member, leaving her without identification, access to her income, or financial security. Although authorities were contacted and additional supports were initiated, this situation has not yet been fully resolved and left the patient feeling isolated and overwhelmed, both financially and emotionally. Because transportation support remained available beyond the initial visit, MIH was able to leverage the HIPAA-compliant rideshare program through Kaizen Health to ensure the patient could continue attending her scheduled mental health appointments when MIH was unavailable to transport her directly. This continuity of transportation helped prevent missed appointments and allowed her to remain engaged in care during a highly vulnerable period. This patient has expressed deep gratitude, not only for being transported to appointments, but for being supported through a series of critical life events. What began as a ride to a behavioral health assessment became a coordinated intervention that restored access to care, safety, and hope. This story illustrates that transportation is not a standalone service. It is the foundation that enables individuals to engage in treatment, navigate crises, and move towards stability. We are incredibly grateful to the Winnebago County Community Mental Health Board and R1 for supporting programs like this, which allow us to walk alongside individuals during some of the most challenging moments of their lives and help them rebuild with dignity and empowerment. Thank you. I'm going to hand it over to Jason for financials.
I'm gonna stay here because I need to click the slides from my computer. But just to remind everyone as well that when we put this into place, the idea was to do a pilot year with this, and see what the outcomes were to determine what level of funding and what scale maybe could be supported in the future. And so I think it was, Reagan's at 7 or 8 programs currently participating. Yeah, so I think it's 6 organizations with 7 programs. So it's not quite at scale for even what the number of funded programs we have are. And it may not make sense for every funded program either, but I think it will make sense for more funded programs as they hear some of the success of the ones that are using it. So the total budget that was approved for this was up to $120,000 for 12 months. And we aligned the start date of that with the program year for the core program grants. So it's running on the same cycle as that. So total spending thus far has been at just 20% of the total budget 6 months through. So we're giving you a half year, mid-year review basically on that. So through June, you see the first month was pretty low. People were just kind of getting onboarded. We see the first 4 months incrementally growing, and then usage went up in October and November, and the costs went up congruent to that. But even still, that's a cumulative number. That's not a monthly total. So we're at 34,000 through November of a $120,000 budget, and there haven't been any months, even with the scale up, that have everything's been under 10,000 a month. So I think we'll be under budget for the year, but with the information that's been given and the programs that are using it and finding success, we do think more programs will want to opt into it in the next program year. And so we're going to continue to monitor those financials and have some focus group conversations with those that are using it to work through some of the challenges they might be experiencing with it, but also to help better communicate what the benefits are to the other programs, and hoping to scale up among the funded programs and then try to estimate or project what type of budget might be needed for next year based on the anticipated number of programs that will be using it. Going the wrong way on my slides here. Any questions? Yeah.
Here's the next 6 months look like. I mean, October obviously was a close, but here's to see what's going to look like.
We are too. Yeah, we'll definitely come back at the end of or close to 12 months and give another update on that as we're monitoring these trends. A couple of reasons. Some that have affiliations with larger um, organizations and maybe an affiliate of a bigger entity there have there's been liability concerns about who's liable for a worst case scenario type situation and are still kind of some are still working through that with their legal departments, not saying no to it necessarily, or that they couldn't use it, but still exploring that. So that's been one of the issues. And then I think the other is just maybe not fully understanding what the benefit might be. We appreciate the early adopters who are willing to explore that with us and share that feedback. And I think as they hear the feedback, not just from us or not just about, oh, maybe what McHenry County is doing or other counties are doing, but what we've done here and how it's benefited here, I think more programs will relate to it or understand better what the local context can be. Yeah. Correct. Actually, the clinician or somebody within the organization schedules the ride. No, they just have to be entered in. So it would be part of whatever intake paperwork they've done to become a client of an agency. It's not protected health information that's going in there. So I don't think there's initial HIPAA related releases of information that are required. But then there's a limited amount of personal information that has to be put into it just to schedule the ride.
Is there some type of documentation that the agencies have to sign to participate in this program?
We have not formalized it with like any contract between the board and the agencies. Reagan, I don't recall if there was something with Kaizen that they specifically signed. I know the mental health board established a policy and that policy was given to those that opted in. I would have to go back and double check though, if there was something officially that they signed with Kaizen.
That dispels liability, that if more agencies would be willing to use it.
A lot of agencies didn't have concerns with it. Like I said, it goes through legal departments that are not in our community, and that's where the only place where we've seen an issue on that particular thing.
Better, more thorough, kind of went, and from the folks were getting information about what they suggest change being made or what they were having issues with, so that we're able to that some recommendations.
Right now for ages. It was a program there's obviously right the individual that receive the services. They expect them to first of all try family member. None of that.
Yeah. I think that just leaves some things to interpretation and so and the feedback we got was just that how thorough do we need to be with the investigation of other opportunities before we click the button that this ride share is going to happen, schedule it.
Hearing none. Moving into other matters. we have none that I was made aware of. So, oh, Jeff?
Sure.
Sure.
I'm happy to talk about it.
Yes.
I had the opportunity, well, this really started with an invitation that I was given through our state association to be part of a conversation in DC in January of last year. It was a behavioral health roundtable convened by NACO, which is the National Association of County Organizations. And while I was there, I met a gentleman, Judge Leifman, and he talked about serious mental illness with an intelligence that I had not quite heard articulated before. I was so well versed on research. He had gone to Italy. He had looked at models across the country, across the world, and was very impressive. So I had a follow-up conversation with him and just wanted to learn more about it. And they made us aware that they do this workshop down in Miami to kind of invite people from across the country to learn more about what they've been doing down there for the last couple of decades. And so Alex and I went in April of last year, I believe, or March, and were incredibly impressed by every element of what they're doing across from criminal justice response, from their crisis response to their criminal justice processing to what they were doing at the courts. But then also they had this incredible facility in which they were using as a jail diversion facility. And it's not it wasn't operational when we went there. It was built, and they just kind of walking through, you see the vision of what it will be when it's fully operational, because they've created crisis residential beds in there. They've created, so there's residential spaces, there's places for primary care, there's places for dental. There's kind of this one-stop shop of services for seriously mentally ill and substance use population who are criminally justice involved as a jail diversion facility. So was really impressed by it. And just at that moment in the conversations the board was having, thought it was a really good thing for board to look at in terms of, we were talking about homeless, we were talking about housing issues and things like that. And what's next, what's the future, what's the next big idea. And then they have finally given me the upcoming workshop dates, and then the ones in, I believe, April 9th and 10th will be the ones that aligned that would give us the opportunity to participate. And if you recall, we budgeted some dollars for board members to attend in the last budget that we did as well. So they have, some of it is fun. A lot of it was local fundraising, and maybe it was too much fundraising that it slowed down their process, and maybe that's why it lagged too long. But in addition to the fundraising they had a gym in there that was funded by the Miami Heat, or like a member of the Miami Heat, right? So they've got a different set of community resources than we have here. But they also have in Miami, and I think it was in their, I don't know if they'd call it a tourism district or an area where they had a lot of restaurants and a lot of hotels. For that district, they have a sales tax that I believe was just on restaurants, maybe restaurants and hotels, for a homeless fund. And then that amount that was being used they had like a homeless specialty units from law enforcement. They had, and so that was really what their main motivation or their mission is dealing with homeless and houseless population. But then they've identified that one of those core issues is serious mental illness and substance use. And then a lot of that, their research demonstrates, and the research we've done backs this up, is that a lot of the deinstitutionalization from the 50s and 60s has actually resulted in trans institutionalization. And those people that were chronically hospitalized are now chronically in the criminal justice system, being kind of circled in and out. And so that's why they've put so much emphasis on this particular approach.
Well, the judge, Leifman, he and Catherine Zenoff from, Rockford have really spearheaded, and worked together all these years. So she really promotes this Miami model and is excited that the Mental Health Board has an interest in seeing it. And I think, if any of you are interested, let Jason know. So we can definitely, I mean, it's going to be more than the Mental Health Board. The invites have gone out to city officials as well as county. And so we'll see how large a group they will allow, number one, and then how many people are interested. So it is an exciting concept for sure. Okay, we need a motion for adjournment. Dick isn't here, so who's going to take, Mohammed, you want to do, you seconded it, okay. Okay, all those in favor, please say aye. Opposed, same sign. Thank you all for coming.